All right, well, today I'm going to talk to you about the use of pathology surrogate markers in Fabry, and we've already talked quite a bit about that, so some of these background slides should go by fairly quickly. As we've said, it's an X-linked recessive disorder leading to a deficiency in the enzyme alpha-galactosidase A. This deficiency leads to the accumulation of the lipid globotriaosylceramide, or GL3. The disease is observed in male hemizygotes and female heterozygotes depending on the pattern of lionization, that's the random X inactivation that occurs in the females. Signs and symptoms include progressive renal failure, congestive heart failure, arrhythmias, MIs, angiokeratoma, hypohidrosis, acroparesthesia, and stroke. The average lifespan in the males is about 42 years, and this is due to end-stage renal failure. And all of these signs and symptoms share a common etiology, and that is vascular injury. So just to go over a little bit about what is known in the literature about vascular injury, and in particular in Fabry disease, we know that the endothelial cells are responsible for the maintenance of a continuous anticoagulant vascular lining. Injuries to these cells attributed to GL3 accumulation leads to vasoconstriction, inflammation, accelerated atherosclerosis, and thrombosis. There have been studies which have shown that markers of endothelial cell injury and activation, such as these listed here, ICAM, VCAM1, P-selectin, as well as markers of leukocyte activation and coagulation, are present at abnormal levels in Fabry disease. And it's interesting to note that, in fact, a number of these markers are also elevated in atherosclerosis, in cardiovascular disease in the more wide population out there. And this certainly suggests that the vascular endothelial cells of these Fabry patients are in a chronic pro-inflammatory and pro-thrombogenic state. And of course, as a reminder, the pathognomonic lesion of Fabry disease is the angiokeratoma, those lesions and superficial lesions on the skin. And these angiokeratomas are themselves vascular lesions involving vascular injury and thrombosis and the resulting marks you see on the skin. And they're certainly likely reflective of the vascular disease going on throughout the body that we don't see. So I thought I'd go over some of Emil's criteria for a good biomarker and relate that to Fabry tissue biopsies. Well, the cause of the disease in Fabry is clearly understood. I think that's quite true. We know that the deficiency of alpha-galactosidase A causes an accumulation of the GL3 due to its direct, markedly reduced metabolism. The pathophysiology is reasonably well understood. We know that GL3 does accumulate in the vascular endothelial cells throughout the body. The drug mechanism of action is direct and unknown. Certainly we know that the recombinant enzyme targets the mannose-6-phosphate receptor. It's a receptor found in cell surfaces throughout the body. This delivers the enzyme to the lysosome through receptor-mediated endocytosis, thus directly replacing the existing deficiency. The biomarker has direct relationship to the disease process, and that's true. We know that GL3 accumulation is a sort of direct result of the enzyme deficiency. It's very closely linked to that. And finally, the readout of changes in the biomarker are clear. And I think that's quite true too. The presence and the absence of the GL3 in the tissue biopsy sections are easily visualized pre and post-treatment, and we'll go over some of that today. So our approach to the trial was as follows. Biopsies were actually taken from 3 organs, from kidney, heart, and skin. Just to get a little technical here, but I think it's important, particularly from an LSD perspective, because the substrate in many of these LSDs is very labile. It's very prone to loss through traditional laboratory methods. So these biopsies were fixed in glutaraldehyde, processed into epoxy resin, which is typically used for electron microscopy. But what you can also do with those epoxy resin blocks is cut what are called semi-thin sections, We stained them with a Richardson stain, which is a mixture of methyl and blue azure 2, and we were able to examine them by light microscopy. So this produces a kind of high-resolution light microscopy, which preserves the lipid very well, much better than conventional laboratory methods used in a hospital laboratory, on a daily basis, I should say. These ultra-thin, this also enabled us to cut ultra-thin sections, which you could process for electron microscopy and examine as confirmation of light microscopy observations. So we did do this as sort of, we made EM prints as supportive and sort of confirmatory images for the pathologist to go back and look at to assure themselves that what they were seeing at the light level was indeed also happening at that ultrastructural level. As has been mentioned here, clearance of GL3 from the capillary endothelial cells of the renal tissue was chosen as the single primary endpoint, and clearance from capillaries of the heart and skin were secondary endpoints. And then finally, we also assessed the clearance of GL3 from other cell types of the kidney as well for completeness sake. One thing I'd like to mention, I think it came up today, about choosing the capillary endothelial cells of the interstitium of the kidney or the peritubule capillaries. The reason that was done was a couple of reasons. First of all, those are capillaries that we could be reassured that were always going to be there in every biopsy. Sometimes you get a renal biopsy and there may be no glomeruli there, or in the case of some of these Fabry patients, the glomeruli may be completely scarred and there are no glomeruli in which to assess the glomerular capillaries. So while from a theoretical point of view, it would be nice to have the filtration apparatus itself as the primary endpoint, in reality for this disease, that would mean that some patient biopsies would not be able to be graded for that reason. And in fact, we had a range of patient ages from, let's see, about 19 years of age to, I want to say, around 42. And those older patients had quite a bit of glomerular sclerosis. So that was the limitation there, and that's why the interstitial capillaries were really the best thing to choose for this particular application. So we had, for each of the organs, we had 3 independent pathologists. So we had, for the kidney, we had 3 independent renal pathologists. They were blinded to treatment assignment and pre and post biopsy sampling. As I said, it was a light microscopy assessment, and it was graded on a scale from 0 to 3, so a semi-quantitative scale. Now, this was developed in conjunction with these pathologists. We sat around a multi-headed microscope looking at these slides, carefully developing the criteria for each of the scales, 0, 1, 2, and 3, and how we were going to do that to make sure everybody agreed before the blinded reading went forward. The other thing you should know is that semi-quantitative scales are used in pathology every day. And in fact, pathologists use them for things like transplant, for tumor grading the aggressiveness of tumors. They also use it in the evaluation of liver fibrosis. So semi-quantitative scales are used every day to guide clinical treatment. And so development of this kind of scale was really something that was quite comfortable for pathologists. Oh, and then I should say, at the end of the day, what we wanted to see was what percentage of the patients had 0 scores. So we really wanted to see this stuff gone. You know, we didn't want to see 2s and 3s. We didn't want to see a lot of this hanging around. Our real ultimate goal was, can we get these patients to as close to normal as possible? This is a summary of each of the grading scores, and I won't go into it, but it was extensively descriptive, even more so in the booklets that each of the pathologists was given, which described the criteria for each of these numbers to remind them as they went along what each of these represented. And there were also images, representative images, which represented each of these scales. These were the endpoints for the kidney. As I said, the interstitial capillary endothelium was the primary endpoint, but we also examined clearance from these other cells as well. So, okay, so one of Emil's other criteria was the sampling compartment predicts the disease compartment. And so we're really sampling the disease compartment here directly. Here is the kidney biopsy. These are the interstitial capillaries you can see here. And the dark blue granules, often adjacent to the nuclei, which appear lighter blue, represent the lipid accumulation, the GL3 here. You can see it, the small granules along the edge here. And post-treatment, we see that these granules have been completely cleared from this compartment. So I mean, this is a 0. This patient would be a 0 post-treatment. And this is a summary of the primary endpoint in terms of the number of patients with 0 scores. And you can see in both the placebo group when they crossed over to treatment, as well as the treatment group, which received treatment throughout the entire trial. If you put all of these together, 98% of the patients had a 0 score in this compartment. So that was really great. And then we looked, for completeness sake, because we did have these biopsies, and there was a lot of information in the biopsies when you looked at them, we looked at some of the other cell types. So we looked at interstitial cells, which comprise the fibroblasts and macrophages which reside in the interstitium. And here you can see very heavy loads of GL3 in these cells, these big dark blue granules, and post-treatment, again, we get very nice clearance. We also looked at larger vessels. We looked at the endothelial cells of small arteries. You can see, again, heavy GL3 load here. We also looked at the accompanying smooth muscle cells around them, and they also had very heavy GL3 load. And post-treatment, we got nice clearance in both of those compartments. Here's the glomerulus. A lot going on in the glomerulus, obviously. Here are the capillaries. Here's some examples of the GL3 in the capillaries, and you can see post-treatment we get nice clearance here. Let's see, I think I have a separate one showing. Okay, here's the mesangial cells of the glomerulus, just with the arrows pointing out the GL3, and again, we had very nice clearance from the mesangial cells. And the podocytes, of course, represent a particular challenge for these patients. We did see a reduction in the podocytes, although not complete clearance at the 12-month time point. But one has to think about the difference between podocytes and some of these other cell types that we've looked at. Podocytes are a terminally differentiated cell by and large. Endothelial cells, by contrast, turn over about every 100 days or so. You can argue with that, but endothelial cells here, podocytes on the other end, are on two very different ends of the spectrum. So when you're looking at the podocytes of an untreated patient, you're looking at a lifetime of accumulation of GL3. And in fact, there have been reports of fetopsies of Fabry fetuses where they looked at the kidneys and already saw accumulation of GL3 in the podocytes in utero. So that sort of gives you an idea of these really specialized cells, what's happening in them. And they certainly do represent somewhat of a challenge. In the cardiac biopsies, we looked at the, again, interstitial capillaries and saw similar changes pre and post treatment. And we looked at superficial capillaries of the dermis in the skin and also saw some very nice clearance as well. So just to summarize, we found that treatment was highly effective in clearing the GL3 from the endothelium, which we felt was critical to stabilizing the Fabry disease progression. Our additional pathology reading demonstrated that the GL3 was cleared from multiple cell types after treatment. And one thing that I think is true of all LSDs is that prevention in the younger patients and then stabilization in older patients is the ultimate goal of treatment. A biomarker such as GL3 or glycogen or some of these other lipids certainly represents primary disease, which is reversible with ERT, but as we all know, we need to treat before the onset of secondary pathology, such as fibrosis, before that renal disease gets advanced, because that end organ damage will be irreversible, despite, clearance perhaps from other compartments. And